Welcome everyone. Today we are looking at Paediatric Emergencies, and it's our Mind the Bleep series from our FY1, Confessions of an FY1. So far you've had a variety of webinars. We are on our second to last one, so Paediatric Emergencies today, and then you've got another session coming up which is on obstetric and gynecology emergencies. My name is Rachel. I'm an F3, currently working in paediatric oncology and hopefully going into paediatrics sometime soon. So today we're going to look at paediatric emergencies, but in particular we're going to focus on across different clinical settings. So our aims for today are to recognise children early and just think about what are you going to do in your first 5 minutes, because we're not aiming to recognise or memorise any very rare conditions, but we want to look at different conditions that you're going to encounter during your F1 or during your F2, and actually then when are you going to escalate to your senior? Who do you need to get involved, or what do you need to have done before your senior gets there? And then we're going to think about any kind of common or dangerous sort of pitfalls, specifically when we're thinking about paediatric medicine. The most important thing to memorize, which I'm sure everybody always tells you when it comes to pediatrics, is that peds are different from adults because children compensate really, really well until they don't. And unfortunately, when they don't, deterioration is then really, really quite rapid. So throughout the session, I just want you to keep asking yourself, if you're alone on the ward at this moment in time or seeing the child in clinic, whether it's a GP clinic, what are you going to do? Because at that moment in time, you will be the only doctor looking after that patient. And during your first sort of couple of weeks in F1, that might be the first time you've ever done that style of consultation. So we're going to go across the settings, like I said. So we're going to start in the GP clinic. Now, not every case that we bring up today is necessarily going to be an emergency, but others will be. So the aim of this is for you to recognise who you are worried about and who you are not worried about. So to start with, case number 1, we've got a febrile toddler. So for each case, I'm going to ask you the questions on the right-hand side. So do you think the observations are normal for age? And don't worry, you don't need to memorize every single reference range for the different age groups. But if you just have a vague idea for a couple of the important ones, that will really, really help you. And you can get up an observation chart. I will show you it on the next slide, so don't worry if you're not sure. Then I want you to think always, are there any red flags? And if this is you in the GP clinic right now, what are the next steps that you are going to take? Okay. So you've got a 3-year-old who's come in. Mum's told you that he's had a fever for the past 36 hours. He's got a reduced appetite and he's drinking a bit less than usual, but he is still playing intermittently. You take his observations and you find that his heart rate is 148. His respiratory rate is 30, his temp is 38.7, his CAT refill is 2 seconds, and he's alert. So to start with, let's have a look at his observations. Are there observations that we've shown normal for his age? So if we have a look at a 3-year-old, we've got the age on the left-hand side, You can see we've got age 2 to 4 years. Let's have a look along. So if he was appusing a 0, his heart rate would be 95 to 140. So we can see that he's sitting at about appuse 1 for his heart rate at the moment. Looking at his respiratory rate, we're on the upper end of normal, but he's still scoring a 0 technically. Now the temperature, that's something that we need to think about. So 38.7. Why do we think temperature is important in children? And do you know any cut-off age groups? So in a child who is less than 3 months old, if they have a temperature over 38, that's going to be a red flag sign. If they are over 3 months, the temperature is over 39, that's going to be a red flag sign. So at the moment, yes, he has a temperature, but we're not too worried about that. It's just scoring at the moment, but it's just scoring a 1. His CAT refill sign is 2 seconds. What do we think about that? Yeah, that's pretty good, isn't it? Okay. So we've decided that he's probably appusing about a 2. So we're not too worried necessarily at the minute. But what are your next steps going to be as an F1? So what I want you to think about is, what are you going to do immediately is there any other information that you would like to find out from the family? Or what are you going to do in terms of your treatment? Are they safe to be cared for in the community? Do they need to be cared for at the hospital? And do you want to talk to anybody? You are the doctor in the GP practice. So I'm going to let you think about that for a second. Now, the reason I've put this case in, and whether or not you might not do necessarily GP in F1, but you certainly would have a chance of doing it in F2, and most of you will probably have GP rotations in F2. It might seem, oh, well, when I get to F2, you'll have more experience dealing with children. Well, actually, a lot of the time you haven't. During F1, you deal primarily with adults. So the last time that you've dealt with children is probably during your med school placements. So actually, it's really important to think at this moment in time, what would you do if you were in this position? So we're going to try and get a more detailed history. And the reason we're going to do this is because we need to try and identify a focus of infection. So far, we don't have any. We just know that the toddler is generally a little bit unwell. So if we think about different focuses of infection, what are the most common ones then in children? Well, probably ENT infections are going to be your most common, or your chest infections. So when we do our examinations of a febrile child in a GP setting, you're most likely going to do a full system exam rather than just respiratory or just gastro that you would typically do in adult medicine. In pediatrics, we do a much more global examination. So if we think about ENT, could this be an otitis media? Could he have any tonsillitis? If this was going to be from his chest, are there any focal crackles? Is there any asymmetry or increased work of breathing? Thinking about the skin as well, is there any signs of cellulitis? Does he have any non-blanching rash at all? And then have a little squidge of his abdomen. Is he tender at all? Is he guarding? And then if you can't find any focus, you always think, well, could it be a UTI? Because children don't necessarily present with UTIs in quite the same way that an adult would. So always think of, is it a UTI if you can't find a focus of infection? Okay, so first of all, you do an examination and the only thing you find is this. So you're having a look in his mouth and you can see a nice bright red area towards the back. We can't see his tonsils, so they're probably not inflamed. You can't see any exudates, but it is really, really pink. So what do you think is the cause of this presentation? Yeah, so it's probably going to be an upper respiratory tract infection. It's probably a pharyngitis. Do you think this patient could be cared for at home or at the hospital? So as the F1, are you going to be happy sending this child home with his mum? Or do you want to call your senior, or do you want to discuss it with the paediatric registrar at the local A&E department? Hopefully you'll be able to recognise that this child is well, so he can actually go home and be cared for there. But what are you going to advise then the parents in terms of a treatment plan? Does he need any antibiotics? No, probably not if it's just a straightforward viral infection. But we do need to advise mum about kind of supportive treatment that we can do. So remember from our history, there was some slightly reduced feeds and some reduced oral intake. Do you think we mind too much about the reduced appetite? No, probably not. If you're unwell, you don't want to eat a 3-course meal, neither does your child. So when the child's in, if they've got reduced feeding, that's probably okay. However, if they've got reduced oral intake, we are interested in that. So it's really important to safety net mum on the kind of red flag signs for fluid and dehydration. So then thinking about wet nappies or passing urine and whether that is normal or not for him. So the first takeaway that we're going to just think about in this scenario is safety netting. When you are safety netting, your first time doing this will probably be again in your F1 or your F2, and you won't necessarily have done this before. And to be honest, even during your adult placements during F1, you won't really be safety netting people. It's only once you're in ED or you're working in the GP and kind of community setting that you actually really need to think about your safety netting. So when it comes to safety netting children, there's a little QR code at the bottom right-hand side of the screen. And this is a safety netting leaflet that I think is absolutely amazing, produced by Newcastle NHS Trust, that is really good to give to parents. And it's got basically a traffic light system on that I'm going to show you on the next slide. But what we need to think about is what your safety net should include. So the first one is what to actually look out for. So your red flags. Is it reduced urine output? Is it to do with reduced dehydration, sunken eyes, lethargy? And then actually what to do if their child demonstrates those symptoms. And then you need to always explain, well, then how urgent is it? Because some things might occur, like if the child develops a little bit of a rash, but actually it's only on his arm and it just stays on his arm. Is that urgent compared to if he develops a florid rash that's covering 95% of his body? That will guide which hospital, or whether you want to go to the GP clinic, whether you want to ring 111. And then you need to think about which service. So these are the 4 things that your safety net must always include. So this is the safety netting leaflet for parents. Now, it's not perfect. You will know more about the kind of safety netting advice that you would need to give when it comes to ED and more specific things. But from a parent perspective, especially if this is their first child, this is a really, really good piece of information that they can take home and think about, well, when would they actually just contact their GP or 111? So you can see that if they are starting to breathe faster than normal, then actually they definitely do need to seek help. So Amber is not a sort of leave at home and don't worry. It's still seek advice, but they may need to be rushed to A&E by 999. They might be able to drive the child to A&E. Okay. So if we try and just safety net our patient, we're going to go through when to return, what to do at home, and when and where to seek help. So I'm just going to give you 30 seconds or so to have a little think and try verbalizing out loud yourself. If you had to safety net this child at home, what would you tell mum to look out for? Okay. So you might have said that you want her to return if the child develops any breathing problems. So that could include, and then you need to elaborate, what does that mean? Well, that could be if he starts breathing quite quickly, if he's got any recessions, if he's grunting, if he has any pauses or apneas in his breathing, if his lips or face are starting to turn blue, if there's any reduced responsiveness, if he's unusually sleepy or difficulty to wake up, or certainly if it was a smaller child, whether they're inconsolable or got a really weak cry or floppy, that's something that we really don't want to miss. And then thinking about poor circulation. Again, what does that mean to parents? Well, actually, that means, are they mottled? Are they quite pale? Are their hands and feet quite cold? Thinking about then dehydration. So you could safety net them for not passing urine. For example, dry nappies for over 12 hours, or really, really dry mouth, or no tears when they're crying, or unable to keep fluids down. And then the most important thing that you always need to safety net when it comes to children, and the same whether you're recognizing an unwell child in A&E, whether it's in the GP practice or on the ward, if a parent is worried their child is getting worse, that needs to be taken seriously. They have seen the child throughout the progression of this illness, so they are the best ones to comment on that. Okay, so let's see then what else you safety netted. So what could they do at home? Well, actually, parents should be encouraging small, frequent fluids to help intake rather than large volumes at once. Thinking about paracetamol or ibuprofen. Now, the most important thing about paracetamol and ibuprofen when it comes to temperatures is the aim of it is not to normalize the temperature. Yes, it does have some sort of effect to bring the temperature down, but we use it for comfort for the child, not aiming to normalize it. So the other things that then parents can do is make sure that the child isn't overheating if they've got viral infection, and making sure that they're in nice and light clothing, and sort of monitor the urine output. That doesn't mean it has to be mil for mil, but just keep an eye on how much they're passing urine. And then thinking about how alert they are and making sure that they're not becoming more and more lethargic or drowsy. And then making sure that the advice that we've given, well, where is it appropriate to go to? So A&E and urgent assessment if they're rapidly worsening, 999, anything that constitutes a medical emergency, and then 111 if they're unsure, or GP advice if they think it's maybe worsening but not quite bad enough to go back to A&E. Okay. So now we've talked a little bit about A&E, we're going to start moving our cases into the emergency department. Like I mentioned before, you might not encounter children necessarily until F2. However, if you have an A&E placement in F1, you will be dealing with children at some point. So you have a 6-year-old child who has come to see you in the emergency department. She has a cough, she is wheezy, and she's having an increased shortness of breath. She does have a past medical history of asthma, and mum has been giving her salbutamol inhaler at home, but she's just not responding to it. So mum, in a panic, has driven her to A&E, and one of the nurses has kindly taken some observations for you. So when she arrives to you, her heart rate is 160, her BP is 82/59, respiratory rate is 43, and her oxygen is 98% on a non-rebreathe, and her temperature is 37.8. So thinking about the same questions then, are the observations normal for the age of the child, so 6-year-old? Are there any red flags? Are you worried about anything? And what are the next steps as the F1? So for this case, what I want you to do is just jot down on a paper, on your notes on your phone, a couple of notes. What are you worried about? What do you want to find out more about? And what are you going to do? You are the first person assessing this child. The nurse has just kindly done the initial triage, but you are now going to clerk this patient. Hopefully you've had a couple of seconds to have a think, what are you going to do in this scenario? So if we have a look at a heart rate, we've got our 6-year-old, so between our 5 to 12 age group, heart rate of 160. Okay, so we're definitely in the red to start with. Any heart rate over 150 in somebody over 5 years old is going to score highly straight away. Okay, so we've got a respiratory rate of 43 now. Okay, that's also in the red, isn't it? And now we need to think about her temperature. 37.8, well, that's actually not too bad, but that's fair enough. Now, what do you think about the oxygen saturations? Are you happy at 98%? Yes, we're happy with the saturations. However, we're at 98% on a 15-litre non-rebreathe mask. So that should be ringing alarm bells for you. Are you concerned about this patient? Remember, we had our questions before in the last case of, should this patient be going home? Are they going to stay in hospital? Where are they safest? Hopefully, we shouldn't be sending this child home. Okay. So let's think then. We know we're worried about this child. Well, what are the red flags for this child? Well, in terms of our red flags and things that we need to be aware of, in asthma and wheeze, actually oxygen saturations can remain quite normal until late on in the sort of acute deterioration phase. And especially if she's on oxygen 15 litres non-rebreathe at 98%, if her saturation started to drop off and actually on 15 litres you're seeing 91%, we are really, really quite far into the acute deterioration at that point. So red flags that we need to really be thinking about for this child and asking the mom and looking at on our examination are going to be exhaustion. So looking at her work of breathing, is there any reduced air entry? Is there any altered consciousness? So thinking through those typical MCQ questions that you get as to whether is this a mild, moderate, acute, severe, or life-threatening asthma attack? And you need to be able to categorize that in your head. So the other signs that then we are going to look for is kind of poor perfusion and hypotension. Hypotension is a very late sign when it comes to deterioration in children especially. So if you see hypotension, you really need to take it seriously. Okay, so what are you going to do then as the F1? What I want you to do is just jot down your management plan in terms of next steps, exactly what you're going to do. This child is in front of you and you've already recognized that you're worried. So if this was me as the F1, the first thing I'm going to do is call for help early. So you have a child who is potentially who is already in a very serious situation, but who's potentially going to deteriorate further really quite quickly. So the earlier you can ask for help, the better. Whether that means there's more hands in terms of your actual assessment, or just you can assess first and then help will have arrived by the time you've finished your assessment. And then how are you actually going to assess the child? Well, you're going to start your A to E. And it seems really obvious and it seems annoying when anybody talks about emergencies that the answer is always do an A to E. However, it is really, really important. And when you get on your first shift as an F1 and you're on call and you're out of hours on your own, it's really, really helpful to think when you go to actually assess that first unwell patient by yourself, how am I going to go about this? Okay, just do an A to E. Let's start there. So you know what all of the A to E stands for by now. So airway, what sort of things are we thinking about in this child? Well, we're listening for, is there any signs of airway compromise? Is there any stride or is there any wheeze? And then moving on to our breathing. So we're going to have a listen to her chest and then see if the air entry is equal throughout. If there's any reduced air entry, can we hear the sort of effects of the bronchospasm? Different people like to go through their A to E slightly in different ways. Some people prefer to do the examination and then at the end think about the kind of investigations. I personally find it really helpful to go through the A to E and sort of organize or order investigations as I go and request it so that then I know I haven't missed anything. So if you were considering differential diagnosis, is it a wheeze in a child? Is it inhale for in body? Especially if there's a stridor, for example, you could consider a chest x-ray at this point. So that would be part of the lung. So I would include that in B. And then thinking about circulation. So we move on and think about other investigations that you might want to do. So if we start at the hands, we can think about the perfusion. So are they nice and warm? And then move on to the wrists. So we can repeat the heart rate, repeat the blood pressure, and also think about getting IV access at this point if you might need it later. When it comes to any emergency, it's always better to get your access and everything nice and early so that if the patient, whether it's an adult or a child, deteriorates, you have that in place. If you don't, you're going to be in a scramble later on. And it might be that you've put a cannula in and actually you didn't need to, but it's always worth having it just in case. And in children, once we put the cannula in, we often then take bloods off the cannula to save pricking them twice. So think about what bloods would you want to do? Are there any bloods that you would like to do if you think you've got a diagnosis in mind for this child? Then you're going to have a listen to the heart sounds. And just make sure, are there any murmurs? Often when children get unwell or get temperatures, they can just get innocent murmurs. So it's worth documenting that. But also thinking, well, actually, could there be a congenital disease when it comes to children as well? Okay, moving on then to D, so thinking about disability. So we don't necessarily do a full GCS, but you can do an AVPU. Usually in children, it tends to be a bit more productive. And then thinking about the glucose as well. And exposure, obviously, finish the rest of your examination, check there's no rashes, whether you want to do an abdominal exam, and then any other investigations you might want to do. So, for example, in our febrile toddler, in case 1, we could have done a urine dip, for example, if we were thinking maybe a source was urine infection before we'd looked in the throat. Okay, so what do you think then is going on for this patient? What is our condition that we're dealing with? That's it, absolutely. It's going to be an acute asthma exacerbation. So asthma management in children is going to be pretty much the same as in adults. It's just to be treated as an acute severe respiratory episode. And there's a little QR code on the screen that will link you to the NICE treatment summary in asthma for children. And it just splits it into the 2 categories of age groups. So very similar. However, the one thing you need to always remember when it comes to children is the doses are going to be different. You might think at the moment you can't remember any doses for any medications, and that's absolutely fine if you're in that position. But once you've started F1 and you're regularly prescribing certain drugs, whether it is prednisolone, whether it is salbutamol nebs or anything like that, you will just know what the right dose is. And so you won't necessarily look it up each time. However, it's really important to remember in children that the doses are going to be different, and they could be based on age or they could be based on weight. So it's always worth checking. Don't just use your knowledge to kind of prescribe it. Do always double check, because you can make some big mistakes if you don't. So how are we going to go about managing it? Well, during our A to E, when you see something wrong, you correct it. So during breathing, if we've done her oxygen saturations, let's say she wasn't necessarily on a 15-litre non-rebreathe and she'd just come in on room air, SATs or 86%, well, the first thing you're going to do is put her on oxygen. And then you're going to start giving some nebulizers. So we would give salbutamol nebs, and then whereas in adults, sometimes you might use hydrocortisone, sometimes as your steroid. In children, we definitely use prednisolone. And then you can start thinking about escalating. So do you want to then include ipratropium with your nebulizers? And actually, you could then add magnesium to those nebulizers as well. And working up the list, you could then do some IV salbutamol, and then finally sort of IV aminophylline. If you get to the point where you're starting to use magnesium, whether that is putting it in the megs or in the nebs, or thinking about IV salbutamol, you definitely need to have senior help before you get to that point. So this is where I would encourage you to think nice and early on, what help are you going to need at what point? So if you think you're going to need help with the management, try and call someone to help you a little bit earlier on, because chances are they're busy with something. So if you ask for help at the exact minute in time that you need it, there's going to be a delay. So just try and be a bit proactive and preempt what support you might need at what point. And then, as I mentioned before, we just need to really, really be careful, especially in children. I spelled children wrong there, to always check the doses before you prescribe, because medications can be based on the age or the weight. Okay. So we have another patient coming to you now in the ED. You've just sorted out our lovely little girl with a wheeze, and now you've got a lethargic teenager. So we have a 12-year-old whose mum's brought him in with increasing lethargy. He's now got some abdominal pain and vomiting, and he just looks not right. So he's got observations with his heart rate of 160. His blood pressure is 82/59. But his respiratory rate is 49. And you can tell that he's got really kind of deep, labored, quick breathing. His temperature's not too bad at 37.8, but he just looks really, really unwell. So to start with, again, let's think through. Are the observations normal for his age? Are there any red flags? What are you worried about if you are worried? And what would you like to do as the F1? So that's all you've got in the little sort of triage summary from the nurse, and you now need to go and clerk the patient. So let's have a look at his observations. I'll leave the chart up for you for a second. And just think, how worried about this child are you? Can you care for them in a sort of a cubicle or just a normal bed? Do you want them to be in resus? Do you want them to be in minor injuries, majors in A&E? Whereabouts do you want this child to be? So we can see from the observations, his heart rate is definitely elevated. His blood pressure is really quite low, and his respiratory rate is very high. The fact that he also looks unwell and he's got increasing lethargy are going to be really big red flags. Okay, so have a think. What are the possible differentials then for this patient? Okay, so we've got maybe a few in mind, and we can keep those in mind as we go through. So step one, what are you going to do if you encounter this patient that has been sat on a chair in the waiting room? You're going to get help for. And the reason you're going to get help is because this child is deteriorating quite quickly. And you need to start your A to E quick and correct anything as you go along. So working through your A to E, you're going to take your investigations or your bloods as you go, maybe get a cannula in, have a listen to his chest, see if there's any reason why he's working so hard with his breathing. Make sure you have then had a feel of his abdomen and exposure, and checked for no rashes or anything like that, and done a bit of a GCS. So if he's 12 years old, you might be able to do a GCS a bit more appropriately than if the child's 2 or 3 years old. So in terms of investigations then, what investigations would you be most interested in a child? The reason I ask what you're going to be most interested in is because whether you've done your PEDS placement or not, you might have seen that we really try not to over-investigate children where we don't have to, because taking bloods from a child or inserting a cannula for a child is quite a big deal and really quite distressing, both for the child and for the parents. So if we don't need to, then we wouldn't. However, in this case, this child is definitely going to need a cannula. We've seen that blood pressure. We're not going to be happy with that blood pressure. Okay. So investigations that we would do, we certainly could get a blood gas, and actually that's going to come back quite quickly too. So that's going to be really, really helpful in doing an initial acute A to E assessment. And then we can send some bloods off to the lab. So we could potentially do a full blood count, we could do some U's and E's and potentially a CRP to see why he's lethargic and why he's really unwell at the minute. Now, your bloods have gone off to the lab, but unfortunately they're going to take a few hours to come back, as they always do. But your blood gas is available immediately, and one of the healthcare assistants has really kindly gone and run it for you. So just thinking about what are your differentials for a second. Your blood gas comes back and shows that the glucose is 22. Were you correct in your diagnosis so far? So hopefully you're able to recognise that this patient is probably in DKA. Now, the reason I've included this as one of our cases to work through is because children sometimes present in DKA quite differently to how adults would present. So in this case, I did include the abdominal pain and the vomiting, which should be a bit of a giveaway. However, sometimes children will just come in with isolated vomiting, or they will just come in with lethargy. And until you've actually got that blood gas, you're probably not going to be able to work out what's going on, because children often present in DKA as the first diagnosis of diabetes. So how are we going to then manage this patient? Hopefully your senior support has come by now and they will be able to support you in terms of the management. But what are the 3 large principles that we need to make sure we factor in during our DKA management? Okay, so our 3 factors that we're going to take into account are going to be, number 1, IV fluid therapy. And the key thing again that we need to remember is we are now in pediatrics. So the fluid therapy considerations are going to be the volume required. So remember, we have to do it by weight in pediatrics, and addressing the mils per kilo in terms of our kind of deficit. And then we also need to think about what type of fluid is required. This is even more important in pediatrics than I would argue it is in adults, depending on the age of the child. Because if you have a child who is 2 months old, for example, a little baby, and you put them on IV fluids because they're currently nil by mouth, their only form of sugar usually is through breast milk. So if there's any reason, or formula feed, so if there's any reason that they can't take their usual milk, then you need to make sure that you have glucose in that bag of fluids, because they can't maintain their glucose levels in the same way that we can as an adult. So it's really, really important that you take into account what age they are and what fluid you're going to want to put up. In DKA, we also need to think about the potassium and making sure that we monitor that appropriately and make sure that that's included in our fluids, and then our insulin. So the most important thing in terms of a practical sense that you need to make sure is, and that I think I definitely underappreciated when I was in medical school, is that insulin needs to be given after your IV fluids have been running. So you have to do the fluid resuscitation first in DKA, and then you start your insulin. And usually it will be after about an hour to make sure that the fluids are running appropriately and that they're starting to correct those metabolic acidosis that you're going to see. So thinking about then pediatric fluids and fluid prescribing, does this child actually need IV fluids? In this case, the answer is going to be yes. But in another case, if a child came in with vomiting and diarrhea, then you might want to think about whether or not we could give any NG fluids with an antiemetic, or whether they could be an oral challenge if they were coming in with just diarrhea, for example, and they're looking a little bit dehydrated. So we try to avoid IV fluids where we can. And the reason we try to use sort of more oral fluid challenges or NG fluids where we can is because it should be more physiological in terms of how we actually absorb the fluid. But if the child can't tolerate it, or there's poor sort of absorption or nil by mouth, then yes, absolutely, we will use IV fluids. I'm sure you will have seen this over and over again in terms of maintenance fluids for children, but we typically calculate it over a 24-hour period. So we do 100 mils per kilo for the first 10 kilos of weight, 50 mils per kilo for the second 10 kilos, and 20 mils per kilo for the remainder. And the most common fluid that we tend to use is 0.9 and 5 in peds. But we also need to think about our fluid boluses, because our fluid boluses are also going to be different in children depending on how big they are. You're not going to give a tiny baby a 250 ml bolus, absolutely not. But you could give a 250 ml bolus to a 17-year-old, for example, or a 16-year-old. So you just need to think about the age and weight of the child. If you are at the point where you're starting to need to bolus your child because they're potentially severely dehydrated or in shock, then you should not be the only person dealing with that child. So you need to make sure you have senior support if that is you. Okay. So we've seen some of our patients in A&E, and now we're going to try managing the ward bleep. So this, the 3 bleeps that I'm going to show you now are 3 bleeps that I had on one of my shifts not too long ago. So you've just come on shift, you've taken the handover, and you're just starting to work through your jobs. While you're working through some of your jobs, you get in relatively quick succession 3 bleeps from different wards. So you've got a 7-year-old who's admitted with pneumonia, and she's currently on 3 litres of oxygen. Her heart rate is 150, her respiratory rate was 34, and her temp's 38.5. Her CAT refill is 2 seconds, and she's currently asleep. But the nurse is quite concerned about her heart rate increase because it was only about 110 before. Okay, so bleep number 2. You've now got a 12-month-old child who's been recently stepped out of PICU earlier in the day, but since she's been on the ward, she's had some increasing stridor, and the nurse is quite worried about her work of breathing. And then your final bleep, bleep 3, is a 4-year-old who's currently in induction chemotherapy cycle for acute lymphoblastic leukemia. He has a central Hickman line in situ, and he's got a temperature of 38.3, but he's otherwise quite well. So I'm going to pause for a moment, and I want you to think, who would you see first, second, and last? Not just who would you see first, second, and last. These are patients that you're actually going to go and see. So is there anything you can do for the others while you go and see patient number 1, for example? While you're having a think about that, I'm just going to give you a few top tips for managing a ward bleep. So the first thing is it's really important to keep organized and really keep a note of who called, when, where, and why. So did the nurse call at 10 o'clock for a 5-year-old patient who is on ward X for worsening shortness of breath? Or did a nurse call because paracetamol needed to be prescribed? But I would always document what time they called, so that if there's a patient that you need to review, but maybe you don't need to review immediately, but you'd want to go back later, when you inevitably get busy in other tasks, you can actually look down and just think, how long has it been since that review was asked for and I've not yet seen that child? And sit down and identify your priorities. There will be points in time where you will sit and think, oh my goodness, there's too many things to do at the minute, and everybody's just pulling me all over the place to try and see their patient or do prescriptions. So just make sure you have that time to sit down and identify your priorities. I always say it's really important to keep the communication open with the nursing team. So if you are really, really busy and you say you're going to review their patient, that's fine, but give them a realistic sort of target. So don't just say, yes, you will review, but you can say, yes, I will review, but I just have a few really unwell patients or a few other more urgent tasks that I need to do first, and then I will review, so that they don't expect you to come immediately to the ward. That will just help you reduce the follow-up bleeps that will occur when they ask, where are you? Why haven't you come to see the patient yet? And if you're unsure at any point, just talk it through with your senior. Say, these are the list of things that I need to do. Can you just help me prioritize them? Because you're not asking for them to do your job for you. Just how could you prioritize your time more efficiently? Okay. So if we think back to our patients then, so just as a reminder for our bleeps, got bleep number 1, who's our 7-year-old with pneumonia, heart rate increase we're concerned about. We've got a 12-month-old who stepped out of PICU, and we're concerned about the work of breathing with increasing stridor. And we've got bleep 3, who's our 4-year-old who's just started spiking the temperature, but he's in induction phase for chemotherapy with ALL. So who are you going to see first? Who did you choose for second? And who did you choose to see last? Were you able to identify anything you could do while you went to see the first patient? If we just skip back to our bleeps, we'll talk through what order you should go to see them in. So bleep number 2 is going to have to be your priority. There's increasing stridor. We're concerned it's an airway issue. So if you're ever unsure about how to prioritize your bleeps, just think through to A, B, C, D, E. Is it an airway problem? Is it a breathing problem? Is it a circulation problem? So this is definitely going to be a sort of airway or breathing problem. So it's going to be pretty high up the list. And then if we're concerned about a heart rate, but in somebody with pneumonia, well, actually, the first thing you could do is have a look. Is the heart rate high? Well, it's a little bit high, but everything else is sort of potentially okay. So you could think about trying to make the patient more comfortable. And actually, if a patient's got a temperature, often the heart rate will go up as they've got a temperature anyway, because that's a natural body response. So you could ask the nurse, does she think the child is currently unwell at the moment, or is she just concerned about the heart rate increase? What does a child look like? And bleep number 3, if the trick for this question is the child is in induction for ALL, so that means he's probably neutropenic because he's got chemotherapy. Okay, so if he's got a temperature while on chemotherapy, we're thinking neutropenic fever, neutropenic sepsis. So our priority is going to have to be bleep 2, bleep 3, and then bleep 1. Okay, so is there anything that you can ask the team to do before you get to review the patient? So you're going to go to bleep 2 first anyway, so we don't need to worry too much about that. But is there anything you could do for bleep 3 while you went to assess bleep 2? Okay, so if you're, depending on where you're working or what the sort of ward team are able to do, you might be able to quickly get some antibiotics prescribed to get the sort of escalation antibiotics in. All patients on chemotherapy or with cancer oncology patients will have a set go-to in terms of broad spectrum antibiotic that they have when they are febrile. So you can think, could you prescribe that? And could you maybe get the ward team to take some blood cultures or take some bloods in the meantime whilst you go to assess the patient, or at least take some observations for you, for example. So there are things you can start to do in the background. And more importantly, before you go to any of these, I would tell your senior, you have 3 patients that the staff are worried about, 2 in particular that you are worried about. You're going to go and see this patient first, bleep 2, but actually you're probably going to need some help. So let's have a look then at our first case. So the observations for our 12-month-old, we've got a respiratory rate of 52. we've got a heart rate of 168. We've got SATs of 95% on 5 litres of wafting oxygen. Temperature's 38, but there is audible stridor at rest, and you can see tracheal tug, and there's some severe intercostal recessions. And every time you try and approach the child, they start becoming really upset and crying. So what are you going to do as the F1 in this scenario? The first thing, like we've said, is you're going to ask for help. You're going to get your seniors to come and review a child that is this unwell. What are your gut responses in terms of where this child should be cared for? We sort of thought before about should the child be cared for in the hospital or at home in the community, but also in the hospital, then you have to think, should this child be cared for on the ward? Should they be in a high dependency unit or a paediatric ICU? Where are they going to be most safe? Do you think this stridor that's been getting worse on the ward with increasing respiratory distress is going to be safe to manage on the ward? Probably not, depending on how many nurses are available to the number of children that are available. But this is probably going to be close to a one-to-one sort of nursing situation, which means you're automatically going to be in a dependency situation. So thinking about the child, when you would be called to assess this, you need to think it's an airway problem until proven otherwise. So the stridor is going to be an upper airway narrowing. When you see a child with stridor, the child can look quite okay and compensate really, really well until they don't, and then they have a really, really quick deterioration. Why I put in about the child getting upset when you approached is a lot of people would think, okay, well, we need to do our A to E. We really need to go through making sure we listen to the chest, making sure we maybe get some bloods or get our IV access, but actually in an upper airway obstruction, in a child, upsetting them can make the obstruction worse, which then causes them to work harder with their breathing and more acute deterioration. So you have to be really careful on that approach, and that's why you need your senior. So your immediate priorities for this patient is to call for help. And it might be that while you go and maybe take more of a history off of mom or dad, whoever's with the child, that you ask one of the nursing colleagues or one of the other doctors on the ward to bleep your reg or to bleep anaesthetics to try and come and be of support for you. So what do you think this could be in terms of conditions? I'm going to leave you with that question, and then we're going to come back to that in a little bit. Okay. So your priorities is going to be to keep the child calm, minimal handling, and sit the child upright with their parent. That's going to try and improve their breathing and just get them to calm down and reduce the work of breathing. So in your first 5 minutes, what are you going to do? So we're going to have a do's and a don'ts. So the do's is you need to go immediately to the bedside. And the thing is, if you're worried about an airway issue, you need to stay at the bedside until somebody else comes. You can't sort of wander off and just leave them unaccompanied. That child needs to be observed. So this is where you could ask somebody else to put out a call, and you need to think about the high flow oxygen for them. You might have noticed that in the brief, I said that the saturations were 95% on wafting oxygen. That's because if we put a mask on young children, that can sometimes distress them even more. But if they need oxygen, you're at that sort of risk-benefit situation. So we tend to just hold the mask near their face, whether that is 15 litres, whether that is 5 litres, whatever it is, to try and get some sort of oxygen into them. And it's usually a parent that would hold the mask because, again, that's going to be far less distressing for the child than if I was to go and hold it, for example. And then if you can get continuous monitoring on the child, that would be ideal. But again, it might be that putting a SATS probe with the little tape around their finger or their toes makes them even more distressed. So you need to just think a bit carefully. And have a quick assessment of the airway. So is there any stridor at rest? Are they drooling? Are they crying? Or are they sort of talking? Is it muffled? Is it hoarse? Are they can they swallow at all? Is there any choking episodes? You can do quite a lot in terms of your assessment from the bedside. But the most important don'ts are going to be don't lie the child flat, and certainly don't attempt to look in their throat with a tongue depressor. You're only going to make the situation worse. And don't insist on cannulation. So where in other scenarios, we talked about A to E and trying to get in that cannula nice and early. If it's going to cause distress, you need to get a senior anaesthetics is going to be help judge whether that baby needs a cannula or not. So coming back then to our differentials. We had a child who stepped down from PICU. So it could be a post-extubation stridor, could be laryngeal edema, or it could be croup, it could be a sort of viral laryngotracheitis, it could be an epiglottitis, it could be a bacterial tracheitis, it could be anaphylaxis even. But if it's anaphylaxis, you're more likely to see the kind of wheeze rather than the stridor. So you should be able to determine that probably from the end of the bed. Thinking about foreign bodies, in this case, it's quite unlikely when they're on a ward. But if the child's just been in the playroom, for example, then it could be a foreign body. And then also thinking about any retropharyngeal abscesses. But like we said, by this point, you should certainly have other members of the team around you and more senior doctors. It should not be you at this point. Okay, so you're going to call for help. So what I want you to do is just think in the next sort of 30 seconds, what are you going to tell your senior? How are you going to get your senior to come and help you through your SBAR? So you might ask them something along the lines of, you've got a 12-month-old who's post-PICU stepped down earlier today with worsening stridor at rest and increasing work of breathing. The stridor has progressed since she's been on the ward. What I can see at the bedside is tracheal tug. She seems really distressed, and I'm concerned about the upper airway. There's a few differentials I have in mind, but my most important priority right now is I really need urgent senior review and potentially anaesthetics airway support at the bedside. So I'm trying to keep the child calm and upright with the parent and giving them some oxygen as tolerated for now. Please, can you come and review the patient? Now, if you had as I talked about before, notified your registrar, for example, that you were going to go and see this child, hopefully they would also think, okay, this child really needs my attention, and they would come straight away. So you wouldn't necessarily need to ring them at the end of your assessment, but you might need to call the anaesthetics reg. So top tips. When it comes to worsening sort of respiratory distress, just think, is it upper or lower airway? If it's an upper airway, we really need to think about how to keep children calm. If it's lower airway, so thinking more along kind of acute asthma, then you can definitely get involved and try and give them some nebulizers to calm them, to sort of ease their work of breathing. But in an upper airway obstruction, minimal handling does actually save lives. And remember, epiglottitis is the one that we should never, ever miss. For any patient, if they have just come out of ICU or just come out of HDU, they are always your most sick patient on the ward, even if they came out relatively stable, should we say. If any medical staff calls you saying that they're worried about somebody that's just come out of ICU, have a really, really, really low threshold to get them re-reviewed by the ICU team or the HDU team. So just make sure that you do take that seriously. And then pitfalls in terms of children, like we said, children really, really do compensate until they don't. So being reassured by okay saturations, well, actually often in children, when the saturations have dropped, it's really, really quite late sometime. We don't force throat examinations, especially if we think it's an upper airway obstruction, and don't delay escalation. Even if you are trying to manage multiple different things, try and escalate earlier. And actually, I would argue the more things you're trying to juggle, the earlier you should escalate so that you can get that support. And don't separate children from their parents if you don't absolutely have to, because that is going to increase their distress. Okay, so we did bleep number 2. Now we need to think about bleep number 3. So just to remind you, this was our 4-year-old who's in induction at the moment in terms of his chemotherapy cycles for ALL. He does have a central Hickman line and he's got a temperature of 38.3, but he's quite well otherwise. So what can we assume from the information given? And what condition are we dealing with? Well, we talked already about the fact that he's probably neutropenic and he's got a fever. So we're going to be dealing potentially with a neutropenic fever or a neutropenic sepsis. So you should still know then that we have to start our sepsis 6. So this is where you could have asked some of the nursing team to maybe support in the early steps of that sepsis 6 whilst you are dealing with your airway issue before you go back, or asking your reg to go and deal with the airway while you go and deal with the sepsis. This is where we need to learn to divide and conquer during F1 and F2. So in terms of our management for this patient, things you could have done before, we could have got some oxygen on nice and easily. Potentially the nurses may have been able to take some blood cultures, whether that's peripheral and then from the Hickman line itself. And we could have maybe just prescribed the antibiotic really quickly so that it's on the system and we don't delay that. Because remember, that's our crucial hours to get those antibiotics into the patient. And consider whether we need to give any fluid boluses or not. And in this patient, it sounds like he's probably otherwise well, and it's more just a neutropenic fever rather than neutropenic sepsis. But certainly in a high-risk patient, you're going to have a very low threshold again for escalating to seniors. So you would always make sure that they are aware. And then you can monitor things like the urine output to make sure there's no deterioration, or potentially increase the frequency of observations on the ward. And then finally, we had our other bleep, which was our 7-year-old who was admitted with pneumonia on 3 litres of oxygen. So if we have a look at our 7-year-old and we have a look at a heart rate of 150, we're just about borderline here, aren't we, between the two? So it is quite high, and I would want to think more about that. But given the fact that she's got a temperature, we could maybe give some paracetamol, try and reduce the temperature to start with. Naturally, the heart rate is going to come down. But we do need to think, did the oxygen requirement increase? So is this 3 litres up from 1 litre before? Is there any signs of worsening infection? Are the antibiotics that she's currently on working or not working? Just to make sure that you keep her safe. So our final take-home messages from the session is really make sure that you ask for help sooner rather than later. The really nice thing in paediatrics, whether you're in A&E or working with children in GP, or whether you're on a paediatric placement itself, is if you ask for help when it comes to a child, very, very few people will refuse you. So it's much easier to deal with tricky situations. But do make sure you recognise your limitations. Peds regs really want to know about all of the patients and any possible signs of deterioration, whereas in adults, maybe the registrar might want you to just sort of get on with it and do your job and just tell them if you really need them. People always have a really low threshold for children. So really make sure that you keep those lines of communication open with your senior. And if in doubt of what to do, just do your A to E, follow that structure, and then reassess if you're not sure at any point, did your intervention work? And by doing that, you will notice if there's a deterioration or if there's any improvement. And then the final thing is to always work with the MDT, especially in peds. So during hours, for example, you might have a play team that are around that are able to help you with assessment sometimes, or getting cannulas in children, which they are amazing in terms of being able to help you do things like that. But also working with your nursing team, are they able to help find you some charts, or help you with the observations, or help you with your assessment, or help ring your colleague while you're stuck with the child? Really utilize the people around you. So I hope you found that session useful in terms of managing paediatric emergencies. And I'm aware that you've got many sessions normally that will go through the stereotypical sort of management of what treatment you give for each patient. But in this session, I hope you at least managed to think a little bit more about, if you were the F1 approaching this child at that moment in time, whether it's in the GP, in A&E, or on the ward, exactly how are you going to manage it, and who would you call for help and when? So I've got the feedback form on the slide. That is going to generate your certificate of attendance. And then we've also got your some discount codes from Mind the Bleep as well. So I'm just going to leave the feedback form up for you for a second now. And I hope you found the session useful.